Welcome, Professor Dr. Ashok Seth, dear participants, panelists informed me, and my chair, Professor Abdul Chowdhury sir. IPDI tribute to a living legend, Professor Dr. Ashok Seth. Early years, Ashok Seth graduated from the Jawaharlal Nehru Medical College, Aligarh Muslim University, 1978. Later, moving to UK for higher education, he served a cardiologist at the Queen Elizabeth Hospital of Birmingham University till 1988. During this period, he did MRCP London, 1984, and then from Ireland, 1986. He returned to India in 1988 and joined the Escorts Heart Institute, New Delhi. Present day, it is Fortis Healthcare Center. Position held, he is now chairman, Fortis Escorts Heart Institute, chairman Cardiology Council, Fortis Group of Hospitals, adjunct professor of cardiology of JN Medical College, Aligarh Muslim University and National Board of Examination, president, Asian Pacific Society of Interventional Cardiology, APSIC, a legendary interventional cardiologist. Where everybody known, over the past 30 years, he has pioneered numerous angioplasty techniques for India and Asia Pacific region like directional atherectomy, angioscopy, stents, thrombectomy devices, and drug-eluting stent, use of impeller heart support device, failing heart, biovascular stent, and transcatheter aortic valve implantation (TAVI), intravascular coronary lithotripsy, shockwave, one of the highest angiographies and angioplasty recognized by the LIMCA Book of Records. As extraordinary organizer, you know everybody, he is the president of APSIC, past president of CSI India, past vice president Asia Pacific Society of Cardiology, founder, co-director of 5 major national international teaching courses, India Live, India Valves, chief CTO India, AICT Asia PCR, Imaging and Physiology Council of India. He is the associate director of TCT Scientific Sessions and program committee member of EuroPCR. He is the founder, advisory board member of several prestigious interventional scientific bodies across the world. He has awarded lots of awards and recognition. A few I describe here. He is the national honor of Padma in 2003, Padma Bhushan in 2015, PC Roy National Award for the Most Eminent Medical Person 2017 by President of India, National Award of Republic of Spain, Research Cross Order of Isabella the Catholic in 2010, Lifetime Achievement in Interventional Cardiology award by Chayan Foundation Singapore, Golden Pioneer Interventional Cardiology by Asia Pacific, Mason Sons Award by Sky 2010, Master Interventional Cardiology by Sky 2017, and other 85 other international awards. He is honored by doctorate from 6 prestigious universities: Banaras Hindu University, Aligarh Muslim University, Jamia Islamia, MET, Khandakar Mahavir University, and Ship other university. He is an outstanding author and editor on editorial board of major scientific journals like Intervention and Cardiovascular Interventions, Euro Interventions, Indian Heart Journal, and others. More than 350 publications to his credit in the peer-reviewed Indian and international medical journals. A chapter in 30 books on cardiology has been edited. A picture is worth 1,000 words. Like me, I am the lucky person. He is my mentor. He is more than 500 cardiologists in India, also in Bangladesh. For last 3 decades, he learning lots of Bangladeshi. I know from our senior colleagues from the Sohrabuzzaman sir, Munwar sir, from my junior colleagues, Muhammad Ali recently is teaching him from himself. I welcome Professor Dr. Shahid to our IPDI. We are really grateful to you. Thank you, sir. Thank you for your kind presence. Thank you, sir.
Thank you. Thank you very much, Mohsin. I mean, it's always such a pleasure I'm one of you, so I always don't see any difference. But it's just my privilege and happiness that I've trained so many, and so many of my trainees like you, Momenuzzaman and others from Bangladesh have excelled, reached such high positions. I mean, there's Kaisar, there's Mir Jamaluddin. I mean, all the excelled across the world. So it gives me more pleasure than anything else. Now, I think that we should also start. I know that I hope there are lots of fellows listening, and Mohsin, you got to tell me as to what level you want me to pitch it at. So I won't, I won't be beginners. I would want to pitch it at least at mid-level.
Sir, I introduce my chair, Professor Abdul Chowdhury.
Yeah, where's Dr. Chowdhury? Dr. Chowdhury.
Yeah.
And it's
Assalamu alaikum and good evening, everybody.
Alaikum salam. There you are, Professor Chowdhury.
Sir, it's really a pleasure. to have you within us. And our audience this time, because we were talking on a specific procedural method, you can explain at least mid-level.
Okay.
So I hope everybody is evaluating. We will be enjoying your lecture, definitely.
Okay. Here, Professor Afzalur Rahman, Professor Sohrabuzzaman, Syed Ali Ahsan, Dr. Shams Munwar, Dr. Badiuzzaman, Professor Badiuzzaman, Professor Khandakar and Professor Saidur Rahman, which are our expert panelists, sir.
I'm going to start and we're going to talk about calcified lesions. Let me just see what's happened to my share screen. So, new share. Okay, let's see that it comes up. Yeah, it should. Yeah, and do you see it now?
Yes, sir.
Okay, good. So I'm going to now talk about the calcified lesions. It's step by step, but let's just take you through firstly, a bit of the history, which is very important. You know, Mohsin did mention that I returned from England after 10 years. This was in '88 to the Escorts Heart Institute, which was the start of it. Did the first angiogram and the first angioplasty of the Escorts Heart Institute in October of 1988. The institute started with my procedures, should we say. And those were the techniques of the PCI balloon era. We were just doing balloon angioplasties. These were 8-9 French guides, only heparin and aspirin and dextran. There was nothing else, no clopidogrel, no other antiplatelets. We had crude balloons, we had cut films, video recorded images that we used to look at. There was none of these fascinating, sophisticated equipment which you see at the moment. So this was clearly a different world at that time. And we were doing, and I was actually very aggressive right from the beginning. I knew I had the skills, and I modeled myself on Jeffrey Hassler and said I could open up everything in the coronary anatomy. I mean, this is one of those balloon angioplasty days where you have these diffuse long lesions in the RCA. You have an anomalous left main arising from the right coronary sinus with an ostial LAD, as you can see here. And then you have 2 lesions in the circumflex and then 1 in the OM. And you can see that. Now, even in the present era of stents, you'd shudder to think that you would actually stent an anomalous left main, ostial LAD, and then circumflex and long RCAs. Well, I would do that with balloon angioplasties in those days. In those days where dissections, we had very little to salvage patients. This paper, this patient would not get accepted in the journals at that time because most of the editors would say that this is unethical to do such angioplasties. Till I had a 2-year follow-up on this patient, and all the 7 lesions, including the ostial LAD, treated by balloon angioplasty were fine at 2 years, and then they accepted this paper in the International Journal of Cardiology. Those were the stretches of imagination that we were doing with just balloon angioplasties. And of course, that brought us to it wasn't the ideal technique. So in the early 90s, we went on to cutters, drillers, scrapers, burners, directional atherectomy, rotablator, tech device, laser. That's what we were aiming at. And that's how rotational atherectomy, one of the tools that we use for calcified lesions, came. And as soon as rotational atherectomy came, it was 92 that I introduced rotational atherectomy into the country. We were behaving like rotodocs. We suddenly had something different from balloon angioplasty. We had predictable techniques. This is the sort of lesions we would do. Those times it was meant for diffuse disease, where balloon angioplasty often could be dangerous with dissections and acute occlusions. So here's one of those patients. This was then published by, at that time, it was Heart Technology, which owned rotational atherectomy at that time. That's David Arth had the company called Heart Technology. And this was diffuse disease. You can see RCA, a total occlusion, which I crossed at that time. It was diffusely disease right to the crux. You had a long circumflex disease. We couldn't do this with balloon angioplasty. It's easy for us to do it with stents at this time, but those time it was very difficult to do these with balloon angioplasty. Rotational atherectomy, 10 centimeters of rotational atherectomy, treated with just balloon inflations after that. That is post right coronary artery, rotational atherectomy right from the beginning to the crux, and then rotablator to the circumflex. And lo and behold, 10 months later, the arteries are looking pristine. This was taken up by Heart Technology as one of the images which they circulated around the world at that time to show rotational atherectomy actually works in preventing restenosis. And this image was there on the Heart, Boston Scientific, then bought over Heart Technology, and in the Boston Scientific headquarters in the United States, they had this in a collage for a long duration of time as one of the histories of rotational atherectomy. So then I created the first rotational atherectomy physician training program outside United States. At that time, we all had to train in USA to a rotational atherectomy. Then only we could do it. Then only we'd be supplied for it. I actually created the first certification program outside United States. This was then, I trained around 15 to 20 Indian physicians as to how to perform rotational atherectomy. That was 95. Now this is the device which has now gone into use in severely calcified lesions, and therefore now becomes a niche device or a mainstay of treatment of calcified lesions. So let's get to calcified lesion. 8 to 10% of our practice is severely, heavily calcified lesions in most experienced centers. And you see it every day. Diabetics, chronic renal failures, those who've had previous bypass surgeries, those with long-standing lesions, and those with diffuse disease. And by the way, in Bangladesh, and especially more for Bangladesh, is this diffuse disease and calcified lesions. I see more often than I see them in India. So you really have a population of diffuse disease and calcified lesions. They are more prone to be, well understand that, and I won't dwell on this, but we know that these are very difficult lesions. I'm talking about heavily calcified lesions. Mild to moderate or some form of calcification exists in nearly 25 to 30% of the patients we treat. But we talk about these severely ones because they are prone to failure. They are actually cause perforations. These are the vessels which dissect. They relate to stent under expansion, which is clearly a nidus for stent thrombosis and is also a nidus for restenosis. So it's clearly associated with poor outcomes, and there's difficult to treat. And we know it. So here's the what and how. Technical considerations, very important as a basic fundamental for all to understand. When you have heavily calcified lesion, you will often find that you need good guiding catheter support. I at least get 1 or 2 failures from other centers coming to me, which are absolutely calcified lesions, failure to cross. And by the way, you will also know it in your practice. Failure to cross relates to poor guiding catheter support in the first instance. And many of the radialists would realize, many of the, many of the, can we actually have the microphones off for, can we have the microphones off for most of the people so that I can put it on, otherwise, can you mute the microphones?
Arif, mute yourself.
Yeah, so once the microphones are muted, we won't have external sounds. So yes, we realize that you'll find that the guiding catheter supports are usually very good from the femorals because they're usually 6-7 French guides. From the radials, you have less guiding catheter support, and that's why you have all those techniques of balloon anchoring, etc. And quite a lot of times what I see is that when you have a very heavily calcified tortuous anatomy, it's clearly difficult to get across those lesions, more so from the radial. So that is why I would actually guide you that it's got to be 7 French, often extra support guiding catheters, long sheets if you're going from the femoral. For a proximal calcified tortuosity, low profile deliverable stents, the ones which maneuver bends and curves far better, shorter stents. Remember, quite often I would encourage radialists to use support wires because that's what actually provides you the combination of a 6 French radial guiding with the best form of support. So remember the support wires like All Stars, like Grand Slam. Guideliners would be needed regularly, shorter stents if you can't get the long stents in, dilate well the lesion if you can get across it, and buddy wires are often important, along with one softer wire, which is like an BMW, one All-Star or a Grand Slam, because sometimes you may get those stents or wire or balloons which do not go across the Grand Slam, will go across a softer wire because the stents come and hit at an angle on a calcium spur. And yet, if the softer wire, they're able to actually pass the calcium spur. Lesions would have to be tackled with scoring, cutting, or ultra high pressure balloons. And the 3 technologies we're going to talk about is rotational atherectomy, is going to be ultra high pressure balloons, and is going to be shockwave. To tell you, you all have rotational atherectomy at the moment with you. What is missing with you is the ultra high pressure balloons and shockwave, but I'm aware of the fact that it's undergoing approvals in Bangladesh, and by December of this year, you will have both ultra high pressure balloon and shockwave in your armamentarium to deal with. So it's better to start understanding it now. And I think the biggest thing I've got to tell all, and especially the younger generation of interventional cardiologists, is do not implant a stent till it's fully dilated, till you actually show that the lesions is at least 3-4 dilated. So I'm not saying go 1:1 and break the artery open and everything, but you actually, if you are in a 3 millimeter vessel, you have to take in a 2.75, implant, open the lesion up, and if the lesion's nicely open with a 2.75, then you can be certain that at least you won't leave more than a 20% residual stenosis in that vessel. So you have to start understanding that. I also want to put one more important point, that imaging has certainly become very important if you want to give these patients a best result. And when I talk about imaging, intravascular ultrasound or OCT, whichever you are good at, whichever is there in the cath lab, try to use it, especially in calcified lesions, because it makes you understand the normal vessel. It makes you understand the extent of calcification, which is becoming more and more important. And I'll come at the end to that. First, I want to tell you about the technologies and how to use it. And finally, to give the best possible results, to get the best longest term outcomes. So there's been a greater understanding of calcified lesions. I hope all this is very clear. So if I go in and the moment I see a heavily calcified vessel, I will go with a 7 French guide. I know I need the best support. I will try, and if I'm not doing a rotational atherectomy, or let alone, if I'm actually going for it, I'll make sure that I actually have one of the best wires which will provide me support. It'll also be like a Grand Slam and an All-Star, which will take away the curves and bends. That will enable me to get a balloon across. I would actually take, if I can't get a larger balloon across, I'll take the smallest balloon across and dilate it, and I will then step up to larger balloons. I will show you an algorithm which takes away one of the important, but if you have a severely calcified lesion, then all of you must imbibe at least the expertise of rotational atherectomy, which you all have in your armamentarium. And therefore, I'm going to take you through some steps of rotational atherectomy, though in the discussion, I will come back to anything you want to ask me about balloon angioplasty in these patients. So you all, this is something that 100% of us need to learn, master, and use regularly. And this is our savior. Those patients who will be coming to the experts like yourselves from other centers where they have failed to even get a balloon across, or failed to dilate, or even after dilatation failed to get a stent across, are going to require something better from you. And that's going to be rotational atherectomy in those lesions. So we won't go through the console, but we'll go through some basics of it. The burrs which are available are 1.25 up to 2.5. But the problem is that 2.25. But the problem is that at the moment, the higher burrs are not being utilized too much. And therefore, even in India, 2 millimeter burrs are perhaps just a few with the company and are rarely used. So I would say that if I take a rotational atherectomy practice, and I would be doing at least 15 rotational atherectomies, around 15 to 20 rotational atherectomies a month, what would happen is that majority of them would be 1.5, and there'd be a few around 10 to 15% of 1.25, and 10% of 1.75, and 2 would be perhaps 1 or 2 cases in a year. So that's the sort of, so you have to start concentrating that 1.5 burr is going to be your most commonly used burr in 75 to 80% of the patients. These are moderate sized burrs. They go through a 7/6 French large lumen and a 7 French guiding catheter quite comfortably. In a 7 French, you can go up to 1.75 millimeter burr. So you don't need to get to anything like that. These are diamond crystals. I mean, it's a very pecking motion. You just advance it, a bit of a gentle pressure on the lesion for a couple of seconds, 2-3 seconds, pull it back, let the artery breathe, have 20-second runs, and then wait in the normal segment of the artery for the blood to flow, for the debris to clear up, for the microcirculation to be cleared up by the debris, regular institution of nitroglycerine, NTG into the coronary, diltiazem so that it opens up the small microcirculation, and actually keep doing that in a pecking motion till you actually keep moving forwards in increments, and then finish off the procedure. Once you cross it, don't be pushing too hard at it. You don't want to drop the revs. I run the revs at 180 to 190,000 revolutions per minute. Some run it at 160,000 revolutions per minute. No more does it matter. I believe that you get through lesions faster if you run it at 180. And then if you actually decrease those revs, you can actually have more vibrations and get a larger lumen. I must also tell you at this time, the 1.25 burr is a different type of burr compared to 1.5 and 1.75, etc. It's not just the size. You can see that this is an oval shaped burr. This is a 1.5 millimeter burr. But as it gets to 1.25, it becomes a rice grain type of a burr. When it becomes a rice grape type of a burr, there are two precautions that one needs to take. Firstly, its surface of ablation, which is the distal half, which has got the diamond crystals, becomes more thin. And therefore, the surface area of the ablative area becomes smaller. So you actually sometimes believe that you've got a smaller burr, so you will get through faster. You suddenly end up realizing that you're taking ages to get through because the ablating area is lesser. The second aspect is that because it's a pointed type of a burr, it's like a grain of rice. Sometimes it will just go through the lesion without ablating it if you put too much pressure, and then the burr gets trapped, which basically means you can't bring it back because there are no diamond crystals here, and you've gone through what is clearly a lesion which hasn't opened and your burr gets stuck. So there are two precautions one needs to take with a 1.25, that you need to ablate slowly, gently, not believing that just because you've got a smaller burr, like a smaller balloon, that it'll go across very easily, okay? So the other point we want to tell you is that don't continue, the reason you got to pull back after 3 to 4 seconds, I would say, and then let it drain is because you actually want to make sure, but never start and stop the burr in the lesion. Because when the burr starts and it goes from 0 to 180, at the lower speeds, you get dissection. It's only at a higher speeds that there's a differentiation between calcium and the vessel wall, and it doesn't the normal vessel wall. So you always start in what is the normal segment, and you always bring the burr back and stabilize it at the normal segment, rest it at the normal segment, and restart it at the normal segment, and not in the middle of the disease segment. Gradually you get to the tactile feel about it. You start knowing the revs being dropped. You know that you don't want to drop the revs, which is 180,000, say, to less than 175 or 173,000. You start understanding that there's always the good points around it. So while you're ablating, never change the RPMs. Only at the platform place do you actually put the RPMs up, measure it, and then keep burring, and then bring it back to the platform area, and then again adjust the RPMs if you want. Do not allow the burr to remain in one location for a long period of time. Gently put a gentle pressure on the burr, have a good guiding catheter support, and avoid burring in the guide catheter, though sometimes for osteal lesions, we burr in the guide catheter, but I've actually burred the tip of the guide catheter also in a right coronary ostium, where you have to come like this into the right coronary. So that's, I think, is important to understand. The wire connector, make sure you don't tighten it too hard, because you're going to actually compress the burr, and then once you do that, you will find that your speed is disturbed, or you will actually have a coiling of the burr. So you got to remember all of those. I will come to the finer points. Yeah, I think one thing you got to remember is you got to keep the wire as distally as possible. The wire tip is 0.14. but the wire itself is 010, and it's a stainless steel wire. So you can actually cut the tip off from the burr. The wire is made 014 at the end, so that the burr, and it's 010 at its distal, so that the burr cannot go beyond the black portion of the wire. It'll hit that black portion. But if you've got that black portion too proximal, as the burr comes out of the lesion and jumps out, if it hits the black portion of the wire, which is the distal tip of the wire, then it'll cut it off because it cannot actually go past it. So that's where the wire breaks. And therefore, what do you have to do? Make sure your guiding wire tip is distal, but in a large vessel, because wire perforations going into small vessels are one of the commonest causes of perforation for rotational atherectomy. It's not the lesion. At the lesion, perforations will only happen at extreme angulation. But the commonest cause of perforation is the wire in a small branch distally and not lying in the main vessel. So remember that. It's a coil tip at the end, 3 centimeters of it. Now the complications, you have slow flow and no flow phenomena. Those micro, the ablative material, the atherosclerotic and the calcium plaque, which is ablated, is so microscopic that it's usually smaller than the red blood cells and washes down the reticular endothelial system. But if you actually burr a long segment, and if you burr too fast, and if you don't give the artery a time to breathe, that microcirculation would clog up with all the debris. And remember, the debris is not just calcified atheroma. It is spasm as well, which creates microvascular spasm, which goes along with it. A lot of other factors get produced. Microthrombus may be getting produced and stopping flow in the microcirculation. So you've got to remember that and give arteries the time to breathe and instill enough nitroglycerine and diltiazem for that microcirculation. So firstly, of course, prevention is what we've talked about, but let's assume that you actually have prevented and still get slow flow. Remember that it's very important, and that's what it says. All the drugs you use for slow flows is important. And commonly, of course, is calcium channel blockers, and you have verapamil rather than diltiazem with you. You need to understand that, and you need to wait. So never continue to burr if you're starting to get slow flow, because it's only going to get worse into no flow. So you have to stop. You have to actually give intracoronary diltiazem and nitroglycerine. If you find that you have to give it into the vessel, you will have to take the burr out, take a ruptured balloon, take it down the vessel you've been burring, and give downstream. You only start burring once the slow flow is reversed. So how do you prevent it? We used to use the flush solution with nitroglycerine and diltiazem into the flush solution of the rotational atherectomy. We don't do that anymore. We just give it before we start burring. We give it intermittently into the coronary arteries. We prevent slow flow rather than have slow flow. So you have to actually know that you prevent slow flow by pre-treating with diltiazem and nitro prior to burring. You do short runs of burrs. You don't push the burr too much into the lesion to create large particles. You just gently ablate to create fine particles, and you give artery enough time to breathe in between runs. Okay. Now you can actually dissect arteries as well, and that happens because you actually jump out at an angulation and so on. You have to start differentiating when the flow stops. Slow flow has to be differentiated from dissections, and which have to be differentiated from spasm. And you, in your clinical practice, know how to do that. Now let's get to some practical observations as to how to do a rotational atherectomy. When do I use 1.25 burrs? Now, there is a guide wire bias. Remember, these are stainless steel wires. They actually are reasonably support wires. And it comes as as support wires and softer wires, but all of them are very supportive wires. That's the only way the burr can actually track. So what is a lesion like this, as you see here? You actually have the wire which will go straight like this. It cannot take this curve because this is not a soft wire. When it does that and the burr comes, we call this guide wire bias. When the burr comes here, it will ablate this side and not the other side. As the burr comes here, it will ablate more on the upper side. And as it comes here, it will ablate more on the downside and then cross like this. On an angulated branch, you will see that the wire goes like this, and the burr will ablate close to the inner aspect of the carina. And that has to be kept in mind. We call this guy, in subtiles works at an advantage in an eccentric lesion. If you have most of the lesion, and if this was eccentric, it's great. The burr comes, ablates this eccentric lesion, and does a great job. So with a 1.5 millimeter burr, you have nearly a 2.5 millimeter, or 3 millimeter vessel nicely ablated, because it's just eccentrically taken the eccentric off. But on the other hand, if most of the lesion is this side, in the lower side, you will see that it's practically did very little job as the guide wire bias. But the guide wire bias can also cause perforation, because if one uses a large burr here, then you would actually track through the carina and cut cut this angle off, causing a perforation. And let me show you some examples. So in situations like this, you can use a 1.5 burr, but if it's not tracking, and if it's just hitting straight into this plaque, calcified plaque, it will take ages to ablate. It will not try and do that, in which case you have to take a 1.5 burr to be able to track down and have as little interaction, and at least have some ablation of this plaque before going to the 1.5 burr. So this is what you'll see in the next some images. We want to understand that perforations do happen, but if you're careful, you avoid them. And I would tell you that for the last 10 years, I've not had a perforation with rotational atherectomy. It's usually if we oversize the burrs and if we take bad angulations where the guide wire bias is actually moves outwards and hits into, if there's calcium on that side, it's not going to perforate because it's calcium. But if your calcium is on the inner side and it's normal vessel on an outer curve, then as you come, you're ablating and you may actually just go into an angle which perforates into. So be very careful going across angles, use a smaller burr to go across angles, and therefore severe angles. An improper technique, of course, is that you've had angulated wires and so on. So here, of course, we know how to manage perforations and tamponade, so I don't need to tell you that. The first part of our training in interventional cardiology is how to manage perforations, because that's the most lethal complication of angioplasty of PCI anyway. We can discuss the lodged burr in our discussion, but let me show you the first case and have some explanation on this. See, tortuous anatomy. We have, and you can see it's fairly two angles. It's right and left and anterior posterior angulation. Now it's calcified. And this is the diagonal and this is the LAD. So clearly, I've got here a 1.5 burr. No, this is the 1.5 burr. And I just want to for you to understand what a 1.5 burr does. I think there was an injection here. If it's got missed out, I will actually have to, yeah. Just watch this. I think it comes here. See where it goes, the 1.5 burr? It's actually hitting against the complete plaque. It will show you in the next again shot, and I'll freeze it at that time when it comes. See what this burr is doing, you saw that? So then I changed to a 1.5 burr, 1.25, and that one on your right you see is a 1.25 burr. And that's a 1.25 burr, and then it practically passes that area of what you saw, the distal part, and then after that one can go on to that 1.5 burr, and then you actually have that vessel, and then the rotational atherectomy of the diagonal branch with the 1.25 burr is done. Again, small vessel, tortuous anatomy in that diagonal branch, calcified, you can see there's enough calcium, and then you do that, and then you implant a stent into that, and I think we had a good result of that LAD diagonal. So it's important to realize this is, I think the next case demonstrates this thing I was telling you very clearly. You have a circumflex patient with, I think that's right. He's got circumflex, which is previous bypass surgery. His circumflex got high-grade stenosis at the ostia. You have a left vein going into the circumflex. I want you to see what this burr is going to do. Again, at an angle, sorry. And if you actually see this image on the right side, the burr is going to cut through the so a 1.5 burr would actually cut larger through that path, which is the angle, outer angle, and you don't want it to do that. So you've got a 1.25 now, and you see what the 1.25 does. I want you to see it's gone through. There was a great image, I think, is it here? We've implanted stents, but I think it was in the previous one. It actually just cuts through there. You can see that it's cutting through the angle. I think I've got better images, but then it was just 2 stents implanted at high pressures. And I think, this image shows you beautifully, doesn't it? You've actually gone well close to the media, very close to the adventitious case. You can actually automatically even see 2 passages happening out here at that angle. But of course, after stent, everything looks nice and neat. But had it been a 1.5, we could have perforated that angle. So here's a 67-year-old female, exertional angina, PCO was attempted, failed to cross the balloon. Failed to cross the balloon, and you can see it's heavily calcified. Again, you have to have a good guiding catheter support. In this, I think, firstly, we so tortuous and calcified. So what's the approach here? So firstly, of course, that taming of an unstable guide. Okay, so what do we have? We actually then put so we got a XB guiding catheter, a right extra backup guiding catheter. You can see that we have wired it, and then we actually have a guide liner for approaching this heavily calcified lesion. We have balloon dilated this lesion. In our present time, we would do a shock wave to it. And then we implant a stent. There was not much calcification at the lesion. The maximum calcification was at the proximal tortuosities. And this just demonstrates how to get the proximal tortuosities out of the way, which is that you actually put a wire, then you put a support wire, and then you're able to cross it with a guide liner and get your guide liner as deep as possible to be able to cross the lesion. And that's what it was done. So stent delivery, an art in a tortuous anatomy. This is the guide liner. Here it is. The guide liner coming and the stent actually being, and this is there's a post dilatation happening, but you have to try and get the guide liner deep in as a seen here. So that's for the proximal tortuosities. And I think this shows the final result. What is it showing? Stent delivery in proximal RCA. Okay. And that's the final result. So two stents implanted, good result. Now we done outside showed RCA dominant, PTCA tried outside and failed. This is again PTCA tried outside and failed only because it's heavily calcified lesion. Long LAD, diffuse LAD, a huge diagonal branch. They couldn't cross the balloon again through the radial that this did not happen at the bifurcation point. But again, this requires a small vessel. I would go with a 1.25 burr, long lesion. I don't want to clog up the distal vessels. I don't want the debris to be too long, so it's a 1.25 burr. So I'd go in with a 1.25 burr and rotoblade the LAD with a 1.25 burr, and then of course go into the diagonal also with a 1.25 burr. So having LAD, then one goes into the diagonal, and look how gently and slowly I go into the diagonal. Watch this. It is not as if I'm pushing it through. I'm just making sure that I'm just touching it and then gently go into it. So you don't want to do any trauma or damage to that. And then of course the LAD is again done with a 1.5 burr. And that's very imperative that I actually do that whole thing. And then post-rotablation, that's what it looks like, some slow flow. And then you actually stent it, I think it was mini crush to the LAD diagonal, as you can see happening. And so I won't go through the mini crush technique. And then you actually have a pot and I think that's a, yeah, recrossing. And then this is a recrossing through the proximal, always in a double crisscross, a kissing, and then a report. And I think where is the final result? Proximal, not so good. So we put a proximal stent. There was a dissection proximally. Don't need to show you all that, but actually just to show you the final result, which looks very gratifying. Okay, I think I'll take you through the truly undilatable lesion. What is this about? Oh yeah, see in the past, how much time do I have, Mohsin? You've got to tell me, because this is just going to continue. You know, I need to time myself so that you can actually ask me questions. How much time do I have?
That time is not a problem. You go ahead. We are really enjoying it.
Are you okay? Okay. So, you know, this is a patient from Bangladesh, and I just want you to see what happened, because this happens to all of us. This was a patient who had a previous bypass surgery. And this is what I keep saying, that it shouldn't be like this. Lima to LAD, vein graft to PD in 1990, recurrence of angina, stress thallium. This is going back now 6-7 years ago. So, because as we get into the present era, I will show you how we transfer into the present era with these patients. So this is circumflex territory, was ischemic and angiogram in 2010, patent Lima, 90% calcified stenosis of the proximal circumflex with blocked circumflex graft. And the patient underwent DES to proximal circumflex, but this is what happened. You see, the stent got implanted even when the lesion could not be dilated. And I went back through the previous angiogram, and the doctor had implanted the stent, had not been able to dilate the lesion, but still put in the stent. I don't know whether feeling that the stent would keep the artery open, and the stent were underexpanded. And the patient had recurrence of angina 6 months post-stent. So now we're talking about this patient being done somewhere in 2011-12, okay? So it shows underexpanded stent. And that's what it is. All this is a stent. Here's a restenosis within the stent, but the stent hasn't been dilated at all. It was 50%, 60% residual stenosis because of calcium. And previous bypass surgery patients do have calcification. Now, in those days, we actually were stuck with such lesions because you already had a stent there. And this patient came to me then from Dhaka, and I tried to balloon it with a non-compliant balloon, put in a buddy wire inside the stent, and then again with a non-compliant balloon at 24 atmospheres. But you can see that the lesion does not open. So cutting balloon, angiosculpt did not cross, no benefit. At that time, there was no what else apart from rotational atherectomy. So the thing is to ablate the stent. And you can see that what I'm doing is trying to ablate the stent, 1.25 burr, 180,000 revolutions. I don't want to trap my burr, so gentle burring at that particular point. And then finally, after 4 or 5 minutes of burring, that goes through. A 2.5 into 10 millimeter non-compliant balloon at 26 atmospheres does not open it at all. And then I go in with a 1.5 millimeter burr a bit more, and you can see that I'm burring through the stent, and I do a stent ablation. After a 1.5 burr, I take again, this is the one which is nice to see because it actually shows the lesion giving way. And why doesn't it run? It was brilliant. It actually gave way. Here it shows that. So you'll see that it suddenly pops open by keeping it at 22 atmospheres, and here it's opened. And of course, after that, it was much simpler that we opened it up, implanted stent, really made it big, and that patient then remained well. So what do we do now if this guy came in? This is in February 2018. Let me take you now to the present. Again, same thing being done at another hospital by an interventional cardiologist who tried to treat this lesion and couldn't open the mid-segment, as you can see. He had a lot of problems. He was doing radial, and I want to tell you the tips and tricks when you do radial, while doing radials for these heavily calcified lesions, but he couldn't open it up. And you can see that he has not opened it up. So what does he do? He implants a stent distally, goes through the lesion, implants a stent distally and then because the distal had to be done, then he actually still misses the lesion. He implants a stent proximally, and I think he implants there's a third stent going in the middle, or was it the second stent, or was it? But it's still it can't open the middle lesion. So we now have, that's the final result. So he leaves it like this. He's got a stent, he's got two stents, he's got the two stents are before and after, and then he would miss the lesion and put a third stent in the middle, which didn't open up. So he's got a layers of stents there. And then he left that. This patient also had a circumflex lesion. He didn't do it. In February 2008, he just gave up, said, I'm done. This was 3 hours of a struggle that person had had. The patient comes, and this is his result. You can see, not good. All of you would agree. And he's got 3 stents into that RCA with an underdilated lesion. Well, he comes to me in December 2018. I do the angiogram. He's got bad angina. You can see his circumflex lesion. That hadn't been attempted. You can see his RCA has restenosed. You can see that layer of the stent. And you can see brilliantly in this better image how underdone that middle of that stent is, even just by visual. So these days, of course, in the past, we would have to ablate this. Not the best way to do things. Here's my IVUS catheter not going through. I think it finally did go through with some 2 millimeter creation of space just to remove as much of the in-stent restenosis which was there. And you can actually see that though the vessel was, proximally the vessel is 4, really underdilated. 3.5 at that time, undilated. This is, again, these are the vessel dimensions, but there's a circumferential calcification at that particular point. And that's the reason why it wasn't opening up. Well, we nowadays have ultra high pressure balloons. These are balloons which go up to 45 atmospheres. And let me just tell you why they are ultra high pressures, designed to perform, and these are good balloons for such situations. In fact, good balloons for many situations. They've got dual, and this is what you'll be getting. This is going under approvals in Bangladesh. Double layer of double material. They're high profile. They're almost like stents to pass because they're higher profile, but they still behave like balloons. They've got a good folding technology. They're like a slightly worse than a normal, good non-compliant balloon, slightly larger profile, but they do their job extremely well. There's hardly any growth. 10% growth even at 40 atmospheres, and that's the biggest thing. It's the best non-compliant balloon. Think of it like that. I mean, even your non-compliant balloons at 26 atmospheres grow by 0.4 millimeters, 0.45 millimeters at 26 and 28 atmospheres. This balloon grows by 10%, so it'll only become a 3 millimeter balloon, which a non-compliant would at 26, 28 become 3.4 for 3.45. This balloon at 35 to 40 atmosphere will become 3.3. I think that's what you're going to compare it. So it's got control compliance. It does not allow dog boning at all. It just moves up at high pressures. And if you properly size to the vessel, it's actually safer than a non-compliant balloon because it doesn't enlarge. So this is what it eliminates the dog boning. As you can actually see, concentrates the pressure throughout all over the balloon itself. And there's no overexpansion. And therefore, if you're sized appropriately, it actually is the best way to dilate a lesion. And, but the only thing is there are a few precautions that you cannot use polymer sleeve wire. Best to use Grand Slam type of wires, which are or All Stars, because it just at high pressures, polymer sleeve wires will get compressed. And when they get compressed, it'll be very difficult to move the balloon across a polymer sleeve wire, which will get stuck to the balloon inner side because you're going to really 40 atmospheres in these balloons, 45 atmospheres. And you have to be sure that you're 1:1 size. You can't oversize these balloons and go up to 40 atmospheres. Of course, the working limit is up to 55. We commonly go between 35 to 45 atmospheres. And we actually have a trick to increase the pressure gradient gradually. So beyond 20 atmospheres, we keep going up slowly, getting to 30. And from there on, wait for a bit and then go up to 35. And at 35, you actually wait for 20, 30 seconds because lesions give way at that time. And here's the OP and NC. So I just pass an OP and NC, go up to 45 atmospheres and the lesion opens up, as you can actually see. Now the vessel is looking good. And I therefore am clear that this vessel should be 3.5 distally and 4 proximally. And therefore, I've actually now gone up, usually dilated that vessel so that right up to the previous stent, going high up on pressures. We got large MLAs. Remember, the MLAs were there at that time. MSAs were literally less than 3. And we now have 8, 7.7. And we have, at the point of under dilatation, it's 8.6, and the vessel 3.75. And right up to the proximal, I put another stent in because now I realized that the vessel is so under dilated that it is diseased right from the ostium. And we actually have a huge right coronary artery, which is now up to 4 millimeters. And these are now MSAs are up to 12.4 at the proximal end and 9.6 at the under dilated area. And then the circumflex was a bad one. Circumflex, you can see the napkin ring calcification. You can actually see the calcification, which is dense here. Usually, you must remember, if one artery has a calcified lesion, which has given you problems, if you've got a second lesion in another artery to treat, you should be cautious from there on itself, because that lesion is also going to be calcified. So here is this calcification. I actually, therefore, rotablate it. And you can see the 1.5 bar. I'm happy that I've rotablated it. I've got this balloon, which is a non-compliant balloon. It doesn't open it at all. I haven't taken yet the OPN into it. I therefore then take a 1.75 bar. You can see that the non-compliant balloon is still not opening up. You can see that it's a napkin ring calcification. And this is where OPN actually helps. So I think it was in, it was in the previous frame that this OPN, yes, this is the OPN. And I'll just show you that it will suddenly open up the lesion, as you will find here. And there it opens. It bursts at the same time as it opens the lesion. This is at 45 atmospheres. You can see the bursting. Yeah, there it bursts. And it still opens up the lesion at 45 atmospheres. That's the dissected artery with the balloon bursting at 45 atmospheres. That's after stent implantation. I have a great open vessel. And then, of course, I have huge MSAs on this. How does it help? Now, I'm now coming to, these are not mutually exclusive technologies. They are complementary. We need to start understanding that it's not one or the other. For example, you have such large vessels. A 1.75 burr is 2 millimeter burr, will do nothing much to a 4 millimeter artery, as you will see here. So I've rotablate it, which is fine. I actually then do a balloon dilatation, and I think with a 3 millimeter, I've actually done a high pressure balloon, non-compliant balloon, and I think I've opened the lesion enough to actually implant a stent. And as I go to implant a stent, I have a residual stenosis. And I've already implanted a stent and I have a residual stenosis. You can see this residual stenosis, nearly 30–40% of residual stenosis. And then you therefore need, you can't do anything, you're stuck. You'll often be stuck in these sort of situations where you think you've dilated the lesion adequately, and then you suddenly realize that you've got a residual stenosis and the stent is not opening up. And that's what this OPN does. This is a 4 millimeter OPN. Look at what it does. It strains there, and at 35 atmospheres, that lesion opens up. You saw that? It opens up nicely. You do it to the 4, and you actually now have what you call a perfect result. Gosh. Sorry. And you have a good result. So you really need these complementary technologies. You can have rotational atherectomy. The rotational atherectomy will take away that eccentric part, but you may still not get enough. In the present days, we would also use shock wave into this. And let me just get you to the shock wave now. I won't take you through these highly complex cases. I don't know, because it's in the interest of time, but I think CHIP is an important aspect of your lives. I'll take you through this very rapidly. We have bad LVs. We have 25% ejection fractions with diffuse calcific triple vessel disease. They have to be done. And we do them on Impella. We do them on a protected PCI and cardiopulmonary support. I'll show you how bad they can actually be. They can be really bad. So we, of course, were the first ones, by the way, to introduce Impella into Asia Pacific region. And that was in 2007. I was the first one to ever demonstrate Impella live transmission to the main arena of the TCT in 2007. Nobody had done Impellas and in bad LVs. and ever live demonstrated it. So I was I was the first one to ever do that to the TCT in 2007. And that was always considered as the most beautiful demonstration of treacherous cases, which is what both Marty Leo and Jeff Moses said about my transmission. And then it went out of our hands in 2 years' time, but I reintroduced it last year. The support is not the issue. The support is something we'll discuss another day. But I want to tell you about the cases that you and I face, because this 64-year-old, no, let's not go through this. This 83-year-old guy who presents with LVF crashes, CPR, ventilation, 5 days later gets extubated, has marked STT changes, his EF is 20%, PA pressure is 50, his coronary angiogram shows severe calcific triple vessel disease. You can't let him die. He's now alive. He's been extubated, except that he's got a bad LV with marked STT changes. And he's got severe calcific triple vessel disease, as you can see here on a 20% ejection fraction, elevated PA pressures, who's just come out of recent left ventricular failure. He's been living a good life in the past, so there's no reason why you can't revascularize him. And then we've got to revascularize this by rotational atherectomy to the LAD carefully on an impeller, because that's how he's going to tolerate it. A 1.25 burr, making sure there's not much debris, gradually into the proximal segment, followed therefore by a 1.5 burr. And then after the 1.5 burr, image-guided implantation of a stent into the LAD, making it really large, preventing ischemic times. You can see how large I'm making it, but I'm actually making sure that we don't take too many angiographic shots. Then circumflex is also rotablated at the same sitting, as you can actually see. Having rotablated the circumflex, I do a V-stenting of the left main, which was a 0-1-1 bifurcation stenosis of the left main. And there's another thing I want to point out here, which is very important as a technique, because I think I'm not just want to show you cases as a technique. I couldn't get much of the wire into the circumflex, but I've got it doubled up so as to give me extreme good length of the wire, so that my burr doesn't jump and hit this black portion of the wire. So actually I've safely got it doubled up at this time. Having implanted that stent, I've done the V-stenting. It looks great. I was guided, it looked fine, the ostium was good. And then I went over to the RCA, rotablated the RCA and put a stent in here. Now this is 2 years ago, the guy's doing fine. He actually goes to his office and leads a good life. And his ejection fraction of 20% is now up to 40%. So I think these are the things that we have to go. But the worst patient is this. 84-year-old referred to us on an IABP, ongoing chest pain, inotropes, and then what does he have? He had bad disease. He was surviving on his last remaining LAD. We put in an impeller because of his impaired LV function, last remaining LAD, the fact he was in cardiogenic shock, and you can see the impeller going in. But look at his LAD. I think this is the one. I think it's really a sight to see this LAD. Look at this LAD. It is heavily calcified, multiple bends, multiple tortuosities, last remaining vessel. When you got to take these, you got to understand rotational atherectomy and complementary techniques to the maximum. You can see how bad these are. And what is the burr going to do? It takes ages for the burr to cross, because firstly, with a microcatheter, I do get a rota wire across. But you can actually see that what the burr will do, it will just cannot go through those tortuosities. And it will just keep hitting those curves of calcification. It was sticking there, and there was no point upgrading it because there was just no way I could actually get across. So what did I do? I actually burst 6 small balloons into that lesion to try and create some space through the trauma of balloons bursting in this highly calcified lesions. I ruptured 6 balloons to be able to create a space to get the purchase for the burr to actually then start going. And actually that resulted, and you can actually will now see, and I'll just wait for the 20-30 seconds for you to see, that it'll gradually get that purchase enough into that area where 6 balloons had actually been burst to create space. There it crosses. Luckily, burr didn't get entrapped. That's the biggest worry when you're actually doing something like this. Of course, this was followed by a 1.75 burr across all those tortuosities. I had no perforation. The patient was last remaining vessel despite ischemia, and this is his final result, and he lived thereafter. And you can actually see that I've really done a great job on that LAD. 5 hours of a case. Just last 5-7 minutes. Where do we go from here in the present circumstances? We know that these are challenges. We know that high pressure balloons have their limitations. We know rotational atherectomy is a difficult device to master. It actually gets, I mean, I've been doing it now for 28 years. 28 years is a long time. But it's a difficult technique for many people who are now starting to master. It's not easy. It's a whole different device. And that brings us to shockwave lithotripsy because it's far more user-friendly. It's a balloon catheter. You saw that ultra high pressure balloons are balloon catheters. Rotational atherectomy is a different device altogether, but the shockwave is a very interesting tool. It's now available both for peripherals as well as coronary. It's ultrasound delivered at the lesion. You have an integrated 12 millimeter balloon, which comes up to which is nominal at 6 atmospheres. It has marker bands. It has got 2 emitters in the middle that give pulses of ultrasound. It's got a small generator, which is rechargeable generator. It's very simple. It just attaches to a connector out here. Very simple and quick. It's a magnetic attachment. And then it's almost like a balloon. And then you've got a button here, which you keep pressing. And each time you actually press, a pulse gets delivered. And you can keep it pressed at one stage. 10 pulses will be delivered. And the balloon delivers 80 pulses. I think this is perhaps what I would want to show you. It represents what happens. This is what happens inside the balloon. The emitters create a bubble. The bubble creates sonic pressure waves, which are created inside the integrated balloon. These almost like a steam bubble, they actually keep expanding and collapsing and actually generate close to 50 atmospheres of reverberation directly to the calcified lesions, 50 atmospheres. This is what, again, it shows. It cracks calcium in situ, as can be seen here. And I hope that you're being able to see the cracking.
The shockwave intravascular lithotripsy system creates pulsatile sonic pressure waves to modify calcium.
So sonic pressure waves.
It consists of a compact rechargeable generator, a simple connector
cable, which connects, and then it's a balloon catheter.
Lithotripsy emitters enclosed in an integrated balloon.
So 2 lithotripsy connectors for the coronaries.
Lithotripsy, the IVL system minimizes trauma, optimizes
the profile is slightly larger. Its profile is larger than the non-compliant balloons. So multiple times, you might just have to dilate a very severe lesion. And this is how it's placed across. And you just expand it to 4 atmospheres, not high. And the moment in front of your eyes, you can actually see it. And at 4 atmospheres, you'll see the lesion give way. And then just go up to 6 atmospheres and bring it down.
The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium.
And
Emitters along the length.
And that's how it opens up.
A localized field effect is created, a small electrical discharge.
So that's how it opens up. And I think won't take you through time. You'll be getting this, and it'll be available to you. That's why it gets so important. It comes from 2.5 to 4. You just have to inflate it to 4 atmospheres. It's just like a balloon, goes through 6 French guiding catheters. And you can actually see intimal cracks of calcification happening, better for circumferential than eccentric calcification. And by the way, we next weekend, while you're all at it, next weekend on Saturday, I'll be sending you the APSIC webcast, the monthly webcast. This time it is on severely calcified lesions, new tools, and the worst cases that I had. So I'm going to send you the program very shortly. Remember, it's on next Saturday evening. So this is just, it shows the cracks in the calcification, but let's not go to the thing. now getting to the last few. So now that we got three things in our system, what's imaging, I told you, was becoming a mainstay. And those of you who have got OCT should use it more often. Those of you who haven't got OCT should try and get it, because what's gradually being seen, and over this time, it's now quite clear that for calcification, what matters is the length, the extent of the calcification and the thickness of the calcification. The length, I think, is the least important. Greater than 5 millimeters is supposed to be a point. But I believe that this is the least, because most of us, when we do lesions, are heavily calcified for a longer length of segments rather than just 5 millimeters. But I think what matters is the thickness, and the greater than 0.5 millimeter thickness or greater than 180 arc of calcium. So remember this as half. That's so half, greater than half the arc of calcification, which is 180 degrees of the vessel, and greater than 0.5 millimeter of thickness, which can only be seen in OCT. You actually do need to use some form of a plaque modification tool, either rotational atherectomy, cutting balloons, or IVLs. So that is what gets incorporated into your algorithms, as you now know. If I was not going to take you through just angiography, and supposing you did not have the IVUS OCT assessments, and this is what the IVUS OCT assessments are, if the OCT assessments took you to more than 2 points, you actually end up with a lithotripsy. But if it's 1 or 2 points, you can actually use a high pressure or a non-compliant balloons, and then understand whether your balloon's fully open, and then use lithotripsy. But if you got really high level of calcification, like 4, that means you got greater than a 5 millimeter depth of calcification, going up to 1 millimeters even, greater than 120 degree, 180 degree arc, going up to 360. And then you actually, if you've got circumferential calcification, in large vessels, you require lithotripsy. But in many a times, lithotripsy balloon won't cross. For that, you will require rotational atherectomy to get at least some ablation prior to giving shockwave therapy. But let's say you have mild calcification, you can actually do a balloon predilatation. That's the simpler, cheaper way of trying to understand the lesion. If the balloon opens up completely, and by the way, go up to at least 80% of the nominal balloon size, and then do a high pressure dilatation to be confident that you're opening it up. And if you open it up, then you're fine to actually implant it, a stent into it, if you haven't got OCT and IVUS. But if you've not got the balloon open up, remember that you've got to actually move to lithotripsy when you will have it. Otherwise, certainly soon you'll have the ultra high pressure balloons to get you that remaining 20% opening prior to stent implantation. But stent implantation should only happen once you're confident that your lesion has opened up. If you haven't, then you have ultra high pressure balloons or shockwave lithotripsy to help you. Shockwave lithotripsy is more expensive, but causes less trauma. Ultra high pressure balloons are very cheap, only 1.5 times to 2 times your normal high non-compliant balloons. But obviously, you're actually going up to 45 atmospheres. So numerous algorithms have been built around. I think you should actually read these up. They're available. I can answer those questions. And the shockwave algorithm also exists. So I introduced the shockwave into India on 11 January 2020 during the CHIP CTO India meeting. This was earlier on this year. And it's almost now a routine for us to use. Let me just take you to the last slides. Large vessels, calcified lesions, left main, ostial LAD, severe heavy calcification are clear indications because they don't respond to rotational atherectomy. I'll show you some lesions which give way very neatly. I think I'll just take you through one example. These are all shockwave analysis of seeing cracks and fissures and combining shockwave with ultra high pressure balloons. You just saw that. So shockwave throughout this vessel, one area was underdilated. So it was at ultra high pressure at 40 atmospheres, and you have a uniform stent expansion, and you have a perfect result, I think, on that vessel, which is here. And I think where's the final result? Okay, let's not worry about it. See, this is not this. So, okay, here's a combination of how you're going to actually do all the three. And that's a very important aspect. I think I'll make this my last case. So you have this heavily calcified LAD, as you can actually see there. It's right from the ostium, diseased. You have a circumflex, which is also heavily calcified. So in this, I do a rotational atherectomy on that circumflex, a 1.25 burr followed by an implantation of a 2.25 implanted, and then you know, up to 2.5 millimeters. And that's the stent, and dilated up to 24 atmospheres, and I got a good result on that. So I'm happy about that. The LED is right from the ostium, as you saw. It actually comes up, it's heavily calcified, and any amount of burring, unable to cross the proximal lesion there with a 1.25 burr, with 2 minutes of burring time with a 1.25, and therefore I dilate it. And you can see the eccentricity which holds my 2.5 NC at 20 atmospheres. This is what you will get. So now I can't get my, so that, but I'm removed enough of the eccentricity for my 1.25 burr to proceed further. But again, it stops there. And again, there's a burring time of more than 2 minutes. In that area, I finally crossed. And then I take my, unable to get across the mid-LED lesion despite 3 minutes of burr time. And then I have a 2.12 millimeter NC balloon, which bursts at 26 atmospheres at that point. So I'm now stuck in the mid lesion, and there's nothing I can do. So I take a guide liner in, and I put a shock wave. Burring has failed. 2.5 millimeter balloon has burst at 26 atmosphere. I take my shockwave balloon, which the tip just gets into that lesion. And you can actually see that I deliver shockwave at 4, this is at 4 atmospheres, and pulses are being delivered, and actually the balloon opens up that lesion. And I give the shockwave all across the proximal segment. After having given the shockwave all across the proximal segment, I get a post-shockwave dissection. That's fine, no problem, but that means that the lesion's nicely open. I then implant stents into that lesion. I go up to high pressure dilatation. I have this result on that heavily calcified LED. I'm able to now look at it with the OCT. I've got a completely great distal edge. I've got no dissections. I've got a complete expansion. I've got a perfect ostial stent placement. You can see I've placed it ostially. This is a circumflex orifice. I've got 2 struts coming outside. I have a perfect result on that LED. So you actually, nowadays, it's easier to deal with these complex high lesions. That was a 3.5 millimeter at the proximal end, and I had opposed the strengths much better in all areas, and this is my final result, as you can actually see there. So we are now in an arena where you can actually do very highly complex lesion subsets with a combination of shockwave therapy, rotational atherectomy, this totally occluded and this tortuous circumflex was dealt by shockwave and ultra high pressure balloons, giving a final good result, which was OCT guided. And I won't take you through this apart from showing you the final result that you have, and you can actually have that kind of a result looking huge in heavily calcified lesions. And you can actually have this left main, which is bad in a 91-year-old bifurcation, 111, being treated by shockwave lithotripsy, followed by ultra high pressure balloons, giving you a very gratifying result like this. So I think my final message is calcified coronary lesions are very difficult, but do not implant a stent if the lesion's not fully dilated. Resort to intravascular imaging, be it OCT or IVUS, whichever you have, get good at it to understand the pathology, therefore to use the right tool and get the most optimum result. And we now have rotational atherectomy, which you should all be able to master, because there would be lesions which you won't be able to cross with balloons. And if you're able to cross with balloons, then you have ultra high pressure balloons or IVL, intracoronary lithotripsy. But all these work complementary. You've seen me use rotational atherectomy, intravascular lithotripsy, and ultra high pressure balloon, all in the same case to give the best results, which are image guided. And so heavily calcified lesions and undilatable lesions require master expertise and understanding to get the best possible result, not just in the acute term, but for the long term as well. Thank you very much for your attention. I'm so sorry that I've given you such a long lecture.
No, sir. We are
so much to talk to.
As usual, sir, outstanding, sir, excellent lecture, as usual before, sir. Thank you, sir. Before our case discussion, so I request Professor Munwar, sir, few comments or any query. Sir, Mohsin sir, do you hear me?
Momenuzzaman.
Mohsin,
yes,
sir.
sir. Congratulations,
Yes,
sir.
Hello.
After Dr. Said, I have nothing to say, just to say salute.
No. Momenuzzaman.
He is the master.
You are a master yourself. Gosh, you are a master
Yes,
yourself.
No, sir. Thank you, sir. Really, it's a great pleasure to see you again. I don't want to give any comment on after your lecture. Just amazingly saw your work and activity, and eagerly waiting for two things in Bangladesh. One is the shockwave and the high pressure balloon. Still, I'm afraid of rotablation. I think this shortwave balloon and opium balloon can give me a lot of, at least, mental stress.
Right. And you know,
but sir, one question to you.
Yeah.
Many a time, I try to handle this calcific lesion, keeping the rotablation standby, and I use scroll billing or one body wire and a regular wire with a high pressure non-compliant balloon up to 24. So almost 95% cases, I succeeded to finish the job without using the rotor. So what is your opinion about this technique?
Good. I would recommend that technique. We must remember that when it gets to very thick calcium, then it becomes difficult to break. So there's going to be a group which is not going to resort to this. But it's actually better than using just plain non-compliant balloons. What you're doing is actually doing that extra bit, which is very good. It's almost like a scoring balloon, where you can even put two wires down and use a very high pressure balloon because you're cutting through the calcium.
And especially if you take a small balloon.
Yeah, so you are actually is creating cracks within the calcium using the wires, almost like you had a scoring balloon, but the ability to go to really high pressures. Now, but then there will be lesions. That's why we say these concentric lesions, the ones which are really concentric, the 360-degree napping ring, will not break with this. What is the other thing is the deep calcification. You may actually break a lesion when you implant a stent. You've got some residual stenosis because you haven't been able to get to the deep calcification. So the reason why we actually are emphasizing that if you are able to study the calcification is, therefore, then you are able to pick up those very lesions which may not actually resort to the same technique that you're talking about, where long lengths and heavy deep calcification may not respond to that.
Yes.
The second aspect is that some eccentric calcifications do not respond to it also, because you can't place your wires on that eccentric part. Your wire may just be going towards the least calcified part, and you're dilating at high pressures, but the scoring is not happening in the calcification. The scoring may actually be the wires are compressed against the more normal segment. So when you go in to dilate, your stent would expand more towards the normal segment rather than the calcified segment. Sometimes that's a sometimes that's a perception that you've opened up the lesion well. But if you actually then see it on IVUS or OCT in imaging, you have eccentric lumen, you have opened more towards the normal segment, and you suddenly realize that if you'd gone up any further, you could have ruptured the artery. So, Momenuzzaman, what we're saying is you are probably breaking the lesion in many instances, but there are some which are not breaking or are actually good angiographic, but poor imaging results.
Thank you, sir.
That's true. Thank
Professor
you,
Abdul Chowdhury, sir.
Thank you, sir.
Professor Abdul Chowdhury, sir. Professor Abdul Chowdhury.
I think this lecture doesn't need any more comments from us, but because we all consider ourselves as a student of Dr. Ashok Sheth. And for a master to comment on that, I can only say, "Tumi kemon kore gan koro he guni, ami obak hoye shuni, ami obak hoye shuni." But there are many questions from the fellows.
Sure.
I think you should pay attention to that.
Thank you, sir. Professor Dr. A.P.M. Sohrabuzzaman, sir.
Well, good evening, sir. It is nice to see you again.
My
pleasure, sir. My pleasure, sir. Last we met in January, I think, Dhaka. So nice to see you. One thing I am always afraid of, the calcified lesions, everybody is looking for calcified lesion over the lesion. But what I faced most difficult to cross balloon or a stent when the proximal vessels, that is proximal to the lesions, is very touchous, and there are also calcifications with insignificant lesion. That is the thing.
So remember,
I have seen you doing these cases. At that time when I was with you, there was no guideliner. In those cases, you used to deep throat the catheter, then push the wire. These are the things we must learn. There are new things has come up. That is shockwave. We hope we will get it, and it is necessary. And one thing I should say, sir, you are getting old. Your hairs are becoming more white, and your experience is getting deeper and deeper.
Thank you.
Pray for us. I pray for your long life.
Thank you so much, Saurabh.
Thank you.
Thank you. Thank you, Professor Badiuzzaman. Professor Badiuzzaman.
Hello, sir. It is an immense pleasure listening to your lecture. It's like a smooth as silk. It's full of knowledge, full of wisdom, and it's just smooth as silk. So it was excellent lecture. As everybody has said, nothing more to add. Just a few query to you. There is a second generation rota coming with there is no the
foot pedal. No foot pedal.
There's no foot pedal and nothing. So have you any experience of using that one?
No, we haven't got it with us in India. And I find that, I would not get adjusted to that. Remember, the foot pedal has been a part. It's like a car. And if you've been driving a car with the accelerator there. Now, if you suddenly had accelerator in your hand, would you be able to drive it as smoothly?
It's a bit, That's yes. Something like shifting from auto gear to manual gear.
Correct. So yes, for the younger, for the new people getting onto it, it probably adds on, makes it simpler, so that you have less coordination. You just have every coordination in your hands. But for people who are experienced with the foot pedal, the newer one is going to be slightly different.
Another question is, so what I know, orbital atherectomy is not yet permitted outside.
Right. We haven't, correct. We haven't got it.
What is the take on orbital atherectomy?
See, the orbital atherectomy had the advantages of being able to use any wire, or there's a wire which comes, but it's 014 wire. It's a better wire. It can act. So you have the wire advantage that you don't have to go for the rotor wire, which are very different, which are not so easy to angle in tortuous anatomy. Also that it can give you, it's a one size burr, can give you a bigger dimension in multiple ways. But on the other, and it's got burrs on both sides, so that even while coming back, you're burring, going forwards, you're burring. But on the other hand, it also has greater chances of dissection. It doesn't recognize between hard tissue versus soft tissue. It gives a higher chances of dissection. It can actually come out. The wire does not stop the burr from going further down, just like this wire with rotablator stops the burr from exiting beyond the wire. So there are a few deficiencies of it. So most of the people, we haven't got it in India. There are some of the countries in Asia have got it, but we've not missed it, should we say, at the end of the day. So there's always, but yes, eccentric lesions, I think it provides advantages because it can actually give a bigger lumen in the eccentric areas. And it's certainly sometimes more trackable. That's how it is.
And sir, lastly, another question is, what do you prefer, the laser atherectomy or the?
We've done laser atherectomies on calcified lesions. There's no question. I didn't touch upon it because you're not going to have it in the near future at all. I touched on those devices which you have available to yourselves. Laser atherectomy, I keep it as a last resort. Some of the, because now we have intravascular lithotripsy, apart from highly eccentric lesions, I really believe that these three provide me the easiest and the most economical pathway, more, compared to laser atherectomy. So this is the pathway that I would most likely follow, though you should keep that for very specific situations.
Thank you, sir. Thank you very much for your
Thank you, sir. Dr. Khalid Mohsin, sir, do you hear me?
Yes, sir. Thank you, sir, for your very brilliant lecture, actually. And I have want to know your opinion about burring in a very angulated segment. Let's say opinion is partial rotablation, not crossing the lesion fully, and complementing it with some other techniques, number one. And number two is, what's your experience about bar entrapment and how to get rid of it when it does.
So you've got to remember that angulation is something that you've got to be very wary about. And the angulations may take a huge curve. When you approach those, you have to be very gentle. That's why I say those are the places where you take a 1.25 burr and you actually go a millimeter by millimeter, assessing the fact as to where your burr is going. Is it taking the curve because of the wire? And you can use a very stiff wire, because there are stiff wires which can actually stay straight, and that's, rotablator has 2 wires. But you must make sure that your burr is actually taking the turn. And the pea-sized burr will take the turn slowly and steadily. The larger burrs may not take that turn. But you really have to be very careful at one particular point where you believe that you're not taking the turn and it's going at an angle, that's when you stop. So you have to feel the lesion. It's the biggest risk of perforation is angulated lesions. So even the biggest experts have had problems at angulated lesions where they believe they could do it and have perforated arteries. The second thing which you've got to be careful about, your wire should never get angulated. Your wire should be deep in. Your wire should always be curved rather than angulated at any stage. The moment it's angulated, you will perforate that artery. Thirdly, you said burr entrapment. Don't push the burr. You have to remember that the more you get impatient and you're pushing the burr, you will entrap the burr. If your burr gets entrapped, it will stumble. If it stumbles and it stops in the lesion, it will get entrapped. So how do you actually get out of it? The steps are, firstly, that put the revs at higher pressures. Try and don't pull the burr, try and shake the burr, and actually then restart the burr at high pressures, at higher revs. You go up to as maximum revs as possible and try and restart the burr. If the burr doesn't still restart, you actually have to try and pull the burr. Remember that the wire will not come out. The wire is actually, if you pull the wire will break. So the whole assembly has to actually come out. You can use the wire to give a traction on the burr, because the wire itself can pull the burr back, but just enough so that you don't break the wire and leave the tip. The third aspect is try to get a small balloon, try to get a wire on the side of the burr and get a small balloon to be able to dilate that just that 1 millimeter balloon. If you can get a 1 millimeter balloon just to the next to the burr by getting a wire down it and then dilate it, you may untrap the burr. And finally, you'd be surprised, people have been as adventurous as doing an antegrade re-entry, going into subcutaneous plane, going across the burr in the medial plane, creating a dissection and re-entering distal to the burr, and then actually expanding that dissected plane to shake the burr and bring it out. So as adventurous as that. So those are the tricks and tricks that you can actually do.
Professor Dr. Saidur Rahman. Dr. Saidur Rahman. Professor Dr. Saidur Rahman. Do you hear me?
Yeah, I'm hearing you. It's just nothing new here, but what we are seeing here actually after this lecture also, because every day we are facing this elderly in Bangladesh, especially the elderly, diabetic and CKD patients are increasing, and every day, at least in my hospital also 3 or 4 cases with heavily calcified lesions we have to treat. Just I want to ask is that sometimes some of the sheet calciums like the circumferential calciums we are seeing even angiographically and looking like moderate to severe calcification, but while stenting, it's not creating that much problem, and we're stenting well, but we don't know that how much actually it has been opposed well or not, because for all the cases the IVAS still is not that much applicable in our country for cost and other issues also, and for a patchy or the nodular calcification sometimes, which we can't predict, there is a problem there. But how we can understand that one other than making an IVAS imaging before? That's another question.
So you're absolutely right. You know, firstly, of course, sometimes we see calcified vessels, which are usually adventitial. They look bad, but they're not so bad.
Yeah.
It's the medial calcification which gives us the most problems, and the eccentric nodular calcification.
Yeah.
Now, the eccentric calcification you're easily able to see because they're dense and it's on an angle, and then it's on one side. And the moment you sort of put a balloon there, you suddenly see everything is on one side. So those are the ones where you don't. But I think whenever you're faced with a calcified lesion, and we often are, and we dilate it and we stent it, I think the three things that one has to say, and imaging doesn't exist with everybody. It only exists with 10% of the people. So let's understand for most people as to how we would approach that. And by the way, we don't every time, I mean, many a times we're actually imaging once we've realized ourselves that, the stent didn't open up and it looks bad, it looks worse.
Yeah.
And that's when we start imaging things. So none of us are perfect. None of us are doing it 100%. So how do we actually approach them is the main thing. So first, of course, I went through all that, how to get the anchoring, everything. So Sohrabuzzaman raised the right point, tortuous proximal calcification. The lesion may not have it. You can't get to it. Of course, we have double wire techniques. We deep throat the guide enough. And now, of course, guideliners should be there with everybody in every lab. At least one guideliner should be there, the 6 French, which goes through both 6 and 7 French, to be able to get down. If that saves you a lot of point of getting to the lesion. Once you're at the lesion, then you've got other things. Always in such lesions which are calcified, you may not want to do 1:1 high pressure dilatation, but you definitely need to do a 0.75 to 1 high pressure dilatation, because that has to be a must. Otherwise, you'll often at times, we will land up in an underdilated lesion, which we think has dilated, but it's at 3.5. If it was a 3.5 vessel, I would go with a 3 at 20 atmospheres before I felt that I'm ready to implant a stent. I may not go with a 3.5 at 20 atmospheres. Okay, because sometimes you end up propagating the dissection up and down, and then you'll have to put a long stent in. Then you say, this was only a 18 millimeter, now got a 30 millimeter, 33 millimeter stent to put in, which may or may not cross. So I would actually, in a 3 millimeter, I would go with a 2.75 and do high pressure dilatation. Then once implanted the stent, I would not finish at that. I would not just say, 16 atmospheres, the result looks great. I would always go in with again an optimum size balloon and go up to 20 and 22 atmospheres. And then I would say, perhaps I've done a good job, which IVUS would have told me. You understand? So I would always in these calcified lesions do a high pressure, non-compliant balloon dilatation at the end, which I visually think is adequate and not under. I may even go up with a quarter size higher balloon of what looks angiographically a perfect result angiographically. We know IVUS-wise is often at times 0.25 to 0.5 millimeter undersized. I would go with a quarter size higher balloon and do a high pressure dilatation of 18 to 20 atmospheres, and then say that I have probably done a good job.
Thank you, sir. Thank you, sir. Professor, Ashok, question?
Can I put in something?
Yeah, yes, sir.
That means whenever we see a railroad calcification, these actually give less problem to us. But whenever we see a eccentric lesion or just haziness, a sort of haziness with some sort of clay calcification, that's the danger sign we should be careful about, isn't it?
Correct. And also long segments of calcification.
Long segments, yeah.
Okay, the very long segments, because those are the ones where at some areas are worse than others.
Thank you. Professor Khandakar, Shahid.
Thank you, sir. Thank you.
Yeah.
So thank you, Mohsin. Thank you, sir, for your great lecture. Sir, for my junior fellows, I want to know something from your lecture, that how they can understand the severity of the calcification solely from coronary angiogram. Number one.
I think most of the discussion we just had was related to trying to understand that. Yes. Go ahead.
Okay, sir. So second thing is, when there is bifurcation lesion and there is osteal calcification, in that case, what should be the strategy? And in tortuous vessel, proximal segment where it is tortuous, what should be the ideal strategy? And for a newer one, which one is perfect? Whether it is lithotripsy or that is rotablation? Which one is more suitable for a newer one?
So for a person who's taking on a new device, it's clearly intravascular lithotripsy, which is very user-friendly. But we have to remember 2 or 3 things. Because it's a balloon, which is a bulky balloon and a larger balloon than even the non-compliant, many a times it won't cross a very severely calcified, highly stenotic lesion, understandably. In those instances, you might have to use a small balloon, a 1.5 millimeter balloon, a 2 millimeter balloon to dilate it to create a space so that the intravascular lithotripsy crosses. The second aspect is that if there's a proximal tortuosity, again, it won't cross, and you may actually have to take a guide liner to go across the proximal tortuosity to cross it. So it's a bulkier device. In those, there are many lesions in which we cross a wire, but even a 1 millimeter balloon doesn't cross, even a 1.5 doesn't cross. In those, you actually have to resort to rotational atherectomy. So rotational atherectomy will always win the day for you in uncrossable lesions and undilatable lesions. But once you're able to cross it, then in larger vessels, intravascular lithotripsy is great because it goes up to the media. Rotablator burr does not go up to the media. It actually only, with a 1.5 and a 1.75, takes away a small amount of plaque and atheroblates small amount of intimal stroke upper medial calcification, inner medial calcification in a vessel which is 3.5 and 4 millimeters. And that's why I showed you one case where my 4 millimeter vessel was still left with a residual stenosis of 40% when I was actually thought I'd done a great job and even dilated it with a 3 millimeter at high pressures. And I was left with 40% residual stenosis after implanting a stent, till I actually had to use an OPN, if you remember that case. So you are actually, therefore you have this issue about nothing is perfect. Larger vessels are going to need IVL and smaller vessels are going to need rotational atherectomy in general. But when you actually put the two together, uncrossable lesions can only be dealt with rotational atherectomy.
Thank you, sir. Dr.
Can I put in another thing? So another thing is that for pre-dilatation of a suspected calcium-rich lesion, we should use NC balloon, isn't it, instead of compliant balloon?
Correct. Absolutely. The only difference is, and I want to tell you, is that even the smallest of NC balloons are larger profile compared to the compliant balloons. So you've got to remember that if you open up a new non-compliant balloon and it doesn't cross a 2 millimeter, then your compliant balloon will cross because compliant balloons are much lower profile than the non-compliant balloons. But they may not dilate the lesion at all. But the problem is, but if the non-compliant balloon goes, that's great because that's the best way to crack them. So let's say you've got a 3 millimeter vessel, which is 90% stenosed. What would be your choice? If you're 90% stenosed and you're confident that it'll cross it, my choice would be pre-dilate it with a 2.75 non-compliant balloon. Okay? So I've now gone in and it crosses, that's great. And then I'm actually going to dilate it to 20 atmospheres because at 20, I know that I'll just about get to 3 millimeters. Okay?
Thank you, sir. Dr. Kaisar Rasulullah Khan?
Yeah. Assalamu alaikum, sir, and good evening, sir. Nice to see you.
Nice to see you, Kaisar. Always good to see you.
Sir, always blessed to be your trainee and learned a lot in Scott days.
So Kaisar, I'll say that the other way around. Now, I'm so proud to see you all. I am the one who's proud. I'm not the other way around. I'm the one who's proud to see all my trainees doing such big cardiologists.
Just waiting for the dinner, sir, which you promised to host in Dhaka, sir.
Kaisar, you're going to be organizing it. Yeah, coordinating it, I'd say.
I'll be blessed, sir. I'll be blessed. I'm honored, sir. Sir, no questions, sir. Just two queries, sir. One is about the lithotripsy balloon. If it is an eccentric lesion, does it work?
This is a great question, and I think I want to tell you all this. Eccentric lesions are the most difficult by any tool, apart from your hope that the guide wire bias is towards the eccentric lesion when you rotablate it. But otherwise, every tool is poor. When you do ultra high pressure, it will only press towards the normal segment. And by the way, if you use ultra high pressure and try to get a 0% residual stenosis in an eccentric lesion or a calcific nodule, you would actually perforate the artery on the normal side, because it will only keep on expanding the stent into the normal side. Even in lithotripsy, the best results actually happen in circumferential calcification because the reverberations go equally. And if it's eccentric, then the catheter itself and the emitters are more distant from the bulk of the calcification in the eccentricity. Now, what happens therefore is, the only way you can overcome it, that you have to deliver a lot more pulses. So what would give way at 10 or 20 pulses, you may suddenly realize that the whole 80 pulses, and by the way, the catheter only delivers 80 pulses. After that, it self-destructs. You can't reuse it. You'll have to get a new catheter out. And it may take all your 80 pulses and still not soften it up. So the way I deal with eccentric calcification is understand the guide wire bias, do a rotational atherectomy first. You might just get enough atheroablation in an eccentric manner to ablate some of the intimal calcification. That will get your lithotripsy balloon closer to the medial calcification in the eccentricity and then deliver enough pulses. That's the only way. Otherwise, there is no device which actually helps those eccentric calcification at the moment.
Thank you, sir. I want 15 minutes from you, sir. 15 minutes.
Yeah. Absolutely. No, it's your time. I'm actually, with you.
Okay.
So don't you worry.
Thank you, sir. Two budding journalists waiting for.
I know, and they're great. I know. I've heard. I must congratulate Aisha Kader. I've heard her present cases, and I think she's brilliant. I haven't met Tanveer Ahmed before. Oh, I may have. But they are very intelligent cardiologists.
Okay, to start your case, Aisha. Yeah.
Let me just share my screen. Sorry. Yeah. Thank you. Thank you, sir, for that very kind introduction. Respected panel of experts, friends and colleagues, very good evening to you all. And thank you to Dr. Seth for that fantastic talk in the run-up to this. So I've been asked to present a couple of cases on behalf of our cath lab showing different approaches to lesion preparation in calcified coronaries. Our first case was a 71-year-old male. He was diabetic and a smoker who presented with CCS class 4 angina and ejection fraction. He had a history of PCI to RCA done 6 years back. This was his angiographic picture. As you can see, there's a very tight bifurcation lesion involving the distal left main ostial LED as well as the ostial left circumflex with around 90% to 95% stenosis in Medina 111. And the calcium can be appreciated in all the images. The RCA stent is largely patent and there's retrograde flow to the left system. Once again, the moderate to severe degree of calcium can be appreciated angiographically on the cine as well. So Dr. Seth mentioned a number of options, but in our resource limited settings, we don't really have much to work with except for NC and scoring balloons and rotablation, plus minus imaging. So in this case, we did approach with a procedural imaging and decided to go for aggressive lesion predilatation of the LED as well as the left circumflex with a very high share of NC balloons, the LED with the 315 NC balloon at 22 atmospheres and the left circumflex with another 2.75 15 NC balloon. And then after that, we went into a DK crush approach because it was a distal left main. A balloon was kept in the LAD and a 2.75 15 millimeter drug-eluting stent was deployed at 14 atmosphere with a slight protrusion into the left main in the LCX. This was inflated to 14 atmosphere. The circumflex wire was then removed and this stent was crushed with a 3.5 10 millimeter NC balloon at 24 atmospheres. Yielding this result. This was followed by recrossing of the wires and a first kiss. In the interest of time, I'm going to skip that. And then the left main to LAD was stented at 14 atmospheres with a 3.5 18 millimeter drug-eluting stent, which was inflated to 14 atmosphere. This was followed by a pot with a 4x10 NC balloon at high pressure, 26 atmospheres. recrossing of the wires and final kissing balloon inflation at around 14 atmospheres here. We did take an IVUS catheter in, as I mentioned before, but I apologize, I can't show you those cines because I couldn't convert it to a suitable format to show by today. And this, of course, was done. After that, we did a final pot, and this is the final angiographic result with rather satisfactory angiographic results. So here we didn't approach with an upfront rota and managed to do the case with high pressure NC balloons. In another case, which I'll show you, is a 70-year-old female with a strong family history of CAD, who also presented with intractable angina on GDMT and a preserved ejection fraction. Her RCA had no significant lesions. So these are the left-sided images showing diffuse calcification. There's an osteoproximal significant lesion in the left circumflex and a long segment diffuse disease involving both the proximal and mid LAD with calcification. This is the still picture where you can appreciate the calcium. So in this case, the PCI was done with an extra backup catheter for better backup, and we adopted an upfront rotablation strategy with a 1.25 millimeter rotaburr and did about 3 runs at 160,000 revolutions per minute. This is the final polishing run. And this is the angiographic picture after rotablation. Further lesion preparation was done with a 2.5 millimeter NC balloon at 16 atmosphere. And a long stent, 2.75 by 38, was deployed in the proximal to mid LAD, inflated to 14 atmosphere. This was followed by post-dilatation with a 310 NC balloon up to 22 atmosphere, being a satisfactory angiographic result in the LAD. The left circumflex was then wired, and here we did sequential predilatation, first with a 210 compliant balloon, then with a 2.510 NC balloon, up to a maximum of 16 atmospheres. Subsequently placed a small stent in the osteoproximal left circumflex with a 2.75 8 millimeter drug-eluting stent, inflated up to 20 atmospheres twice over. Because it was a small stent, we inflated the stent, and this, of course, yielded a relatively satisfactory angiographic result. And these are the final pictures. So in conclusion, I'd say my take-home points are that lesions with high calcium content require adequate preparation, as has been mentioned in the lecture before, for optimal stent deployment as well as outcomes. Each calcified lesion is, however, different and should be treated accordingly. It is important to use the appropriate tool for each lesion to decide on, for example, in our case, upfront versus a secondary rotablation, and this should be tailored according to the de novo calcified lesion. Many calcified lesions can be managed by modern-day NC cutting and scoring balloons as well, as evidenced by the first case. And of course, an intravascular imaging and an approach based on the dedicated tools are key to a satisfactory angiographic result. Thank you for your attention. I'd like to acknowledge my mentor, Professor Syed Rahman, who is also on the panel today, and thank you to IPDI for the opportunity to present.
So Aisha, Dr. Carter, we should discuss this case. I know, Mohsin, I know there's a second presenter, but I think we should have 5 minutes to discuss Dr. Carter's case, so that we should put it into perspective. So there are 2 perspectives to this. No, there are 3 perspectives. If we had imaging, what would we do? Or if we had to decide based on imaging, what would we do? If we didn't have imaging at all, and many centers don't, what would they do? And finally, in the present scenario, or in 6 months later, what would you do? Because all the tools would be there in Bangladesh. Okay, so let's start off by saying, if you didn't have imaging, how would you do it? So if I didn't have imaging, rotational atherectomy in those large vessels is going to only ablate part of the tissue. And certainly going down the circumflex, one has to be more careful than going into the LAT. But if I didn't have imaging and I was an expert at rotational atherectomy, I would still do a 1.75 millimeter rotational atherectomy down the LAD, and I may have actually done a 1.5 down the circumflex. that's in the absence of imaging if I've got a heavily calcified left vein. Because what you really want in the left vein LED bifurcation is to give a result which is the best if you're taking it on, which has to be so good that it has to match the surgeons. So you know that you'll have to give him the maximum lumens. So after that, I would have gone in with the non-compliant balloons, really done exactly as you did with the non-compliant balloons, actually made sure that I actually went up to 20 and 22 atmospheres with the non-compliant balloons after the rotational atherectomy. I mean, I'm saying after the stent implantation. So you would have pre-dilated it at high pressures, like I told you. After the stent implantation, I would have made sure that it was at beyond 20 atmospheres that it was dilated. And then what would I have done to the left main? I probably would have gone to 4.5. I would have actually believed that, see, once you have a 3.5 LED, and what you was, you put a 2.75 into the circumflex, which actually is a 3. So when you angiographically think you've done a good job, remember that you are actually 0.5 millimeters less than the intravascular ultrasound. So you go up with you don't have to go up to 20 atmospheres with a 4.5, but you just end up with a 10 atmospheres, the optimal at a 4.5, you've opposed it, give it the largest lumens. I know you've done IVUS, you probably have done that IVUS and you probably got good lumens, but I'm actually concerned that should have been a 4.5 left main. It's very rare to actually have a 3.5 LED and a 3 millimeter circumflex to only have a 4 millimeter left main.
But Dr. Syed, but that case has been imaged by IVUS.
I know.
Pre and post.
I know you said that, and I would
it has been opposed there.
I would have loved to see that, but 3.5 and 3 doesn't give me the sense of a 4 millimeter left main.
That's true. That's true.
Okay. The second aspect is how do we actually do it now? So it's very clear now. If I was doing you, or 6 months later, how you'd be doing it, you would use an IVL. It's deep calcium. Everything will get abolished. At 4 atmospheres, both lesions, have opened up adequately well. It's easy to cross. There's no risk of perforation down those angles. There's no risk of dissections, huge. You actually would have done most of the lesion, and then your implantations would have been smooth and easy, and that you've taken care of medial calcification as well adequately.
Yeah, actually, that OPN and that shockwave, these two, more than corona vaccine, you're waiting for that one.
That's right.
You're waiting for that one.
And even if you don't have OPN, even if you didn't have IVL, again, your higher pressure balloons would have been OPN. They don't expand at all. So you're much more confident of going up to 20 atmospheres and beyond 25
That's
atmospheres.
fantastic. That's fantastic.
But great job done. Great job done, because you're dealing with really a lot of calcification. And I must tell you, I'm just saying what I would have done in the circumstances, but that doesn't mean you got a great result. The patient's fine. Either you did an IVUS, you did actually what could have been the best. But remember, left mains have to be so perfect because we're competing with surgeons in giving them the best outcomes. We just owe it to the patient that it has to be as big and as large and that they don't return back. So we just have to be sure of our results. Good job. Always.
Dr. Sams Manoj, do you hear me? Dr. Sams Manoj?
Yes, I can hear you.
Yeah.
Dr. Shri, thank you very much. Actually, I went to for a while. Thank you very much for the brilliant lecture. Actually, this calcified lesions is always a dreadful thing for all of us. The cost implication actually has given a lot of problem, but I was really impressed with the result of IVL and the high pressure balloon. Probably that will make our life much easier. Thank you very much. I had some questions, but that has been already answered. So thanks a lot for that.
And Dr. Carter, one more thing, that you did a DK crush, you did a mini crush, that was very good. That's what we should really do in the left veins as much as possible and get better and better at it. And you've done a great job on that as well.
Thank you.
Yeah, I'd like to acknowledge my mentor. Case was done by Professor Syed Rahman Khan.
Oh,
I assisted
Saidur Rahman is anyway an expert. So, but we got to compliment you. He's good. But next time you're going to show the case yourself. Yes, the case you've done.
Yeah.
Thank you, sir. And thank you.
I will go for next case, sir.
We go for the next case.
Yeah.
Yes, sir. Sir, are you listening to me, sir?
Yes, yes, I can hear you.
Yeah, okay. Okay. Is it coming on the screen now, sir?
It is coming.
Yes.
The United Hospital, very
Yes,
nicely
sir.
coming.
Okay, thanks, sir. It's about a rotablation case in an elderly patient. As you said, sir, in our country, we really face lots of calcified patients. And of late, as the age of survival is increasing, and so are the comorbidities, calcified lesions are increasing. So it's about a 75-year-old man. He was hypertensive, non-diabetic. He presented with unstable angina. He was a patient of stable angina and already on anti-anginal drugs. He was doing good, but this time he presented with unstable angina. So we decided to go for an NGO, which revealed he had a non-dominant RCA, but very calcified and almost diffuse diseased LED. Critical lesions 60-70% in the proximal and the mid part, and 90%, almost 90% in the distal part. And the diagonal was also big vessel, and it was having osteal lesion. The LCX was having some lesions, critical lesions in the mid and distal segments.
Until you have to speak up a little bit.
Yeah. So LCX was having some lesions also in his mid part, and we can see a chunk of calcium which was involving the whole of territory of the LED. So it was something which we needed to plan quite well before we would handle the case. So what should be the strategy? We went for a syntax score where both the options were equally possible, and it was offered to the patient, and the patient, knowing the risk and advantages, they opted for a PTCA. So knowing the lesion morphology, age of the patient, we decided to stage the procedure. First we would address the LCX and then the LED. So first for the LCX, we went for a femoral route using a 3.56 French catheter. We took 2 wires, a BMW and a body wire, to get an extra support for easy passage of the balloons, and then subsequently the stent as well. So we did sequential dilatation using smaller size balloons, 210, 212, 215, and gradually increasing the size and the length as well. Then subsequently we took a stent. It was a Synergy 2.25, 38 millimeter stent, which we deployed at 12 atmospheres. We then used 2.5 balloon, a slightly higher pressure. Following post-dilatation, we saw there was some intimal dissection at the distal edge. So we covered it using a 2.25 24 stent. And then the final result was quite good. There was no residual dissection or perforation, and there was TMT3 flow in the LCX. So we discharged the patient, and we opted to do PTCA in LED after a month. Patient came with still anginal symptoms persisting. So we went for a CAG again. As seen before, there was heavy calcification in the proximal to mid segment, and the distal segment, it had a 90% tight lesion, and the calcium as seen before as well. So what was our plan? We decided to go for an imaging upfront to determine the lesion morphology, and then select the hardware accordingly. And then if rota was required, we'd check the IVUS post-rota for successful rotablation and successful stent implantation if there was no stent leg or something like that. So we took a 7 French catheter, we wired with a BMW wire, and then we took the IVUS. But as we can see, the IVUS was actually not crossing the lesion. And when we were pushing the IVUS catheter, the catheter was actually backing off. So we decided to start the IVUS from this segment. So what we get in the IVUS, we can see there is a superficial calcium and almost 360 degrees of calcium. And the limitation of IVUS, it actually doesn't give good pictures behind the calcium. So still picture, what we can see, it's a superficial rim and a circumferential 360 degrees of calcium. So we decided to go for a rota. So we changed the BMW with a micro catheter, changing it to a rota wire. And as Sir said, we actually tried to push the rota wire as distally as possible. So here also we tried to push the rota wire as distally as possible. We took the microcatheter out, then we started the atherectomy. We started with 1.5 millimeter bar at 180 180,000 revolutions per minute initially in the proximal segments, and we are giving some space in between because it was actually a long segment. So we are giving some time for the blood to actually wash out the debris. So after that, we went for the whole segment, the distal part, and then the final polishing. So after rotablation, we again went for the IVUS. Now the IVUS catheter was actually passing quite easily to the distal part. So we took it to the distal most end and then started the IVUS. So the IVUS now is actually showing that calciums have been fragmented or there are some breaks. So the reverberation shadows can be seen behind, and once we take the image in the still picture, we can see there are some dissection flaps and there are some reverberation shadows behind the calcium trunk. So we are quite satisfied that there has been some successful rotablation with some fractures within the calcium. So we went for a balloon dilatation now. Here also we did subsequent balloon dilatation using the smaller than the larger balloons, starting from 2 to 2.75. And then before we stented the LED, we took a wire in diagonal and we did a plain balloon in the diagonal. Then we took a stent, 2.5 48 size in the distal portion of the LED and inflated it. And then a 3 48 size stent in the proximal part. The check shot showed there was no perforation, some indentations were there, but no dissections or perforations. So we post-dilated using initially 315 balloon, and then subsequently the proximal part using 3.515 balloon. So we again did a post stent IVUS to determine whether the stents have been opposed. So this is the picture, this is behind the stent implantation. So we can gradually see the stents opening up after a while. Yeah, the stents are starting to open up and they seem to be opposed quite good with the vessel wall. So we took the MLA, it was quite satisfactory at that time. And the final angiographic show, LED was well revascularized. There was no dissection or perforation, as we can see it here. So this was my case, and as a message, before we deal with calcified lesion, as my mentor always says to me, you should know your weapons and you should know the enemy as well. Here, my enemy was the calcium. So IVUS was very helpful to me to determine the choice of hardware. So take-home message was, we should possibly use IVUS in critical cases wherever possible. Rotational ectotomy is definitely a useful tool along with other options available for dealing with calcified lesion. And when we switch to the contemporary approach, radial approach can be used for rotablation. And I would like to thank my mentor, my guide, Nasrullah sir, from whom I have learned this rotablation, and I was assisting him while doing this case. Thank you, sir.
Thank you, sir.
So that's a very good case. That's a very good case. So I think it was very exemplary. There's, if I have to add anything, firstly, I've got to say that you did a very good job. I think it was good that you tried and image it. These long lesions need the best results, like I keep saying. And unless you image them, you won't get the best result. You had a circumferential calcification. I would have done exactly the same. 1.5 burr was more than sufficient because your vessel at that point, I think on IVUS was not more than 2.5 subsequently. So I think you did a great job with a 1.5. I think you did great implantation. You did IVUS, you made sure that you even went up to a 3.5 proximally. So you tapered the stent from a 2.5 distally to 3.5 proximally. You imaged it to make sure that you had the biggest lumens as much as possible. So I think you did a very good job. You have to be safe in these vessels also, not to rupture them, you know, with the over-aggressive dilatations. So I keep, even after rotational atherectomy and stent implantations, one of the things that, you know, we have learned, and there is some data around it, is that heavily calcified vessels. You can actually even make them even more pliant, not just by rotational atherectomy, then by doing cutting balloon after that. And if you do cutting balloon after rotational atherectomy or scoring balloon after rotational atherectomy, you actually just fracture that calcium even further. Because we must remember, cutting balloons, while they're set for calcified lesions, for severe heavy calcification, they do very little. Remember, they're just blades. They just can't cut through heavily calcified calcium, but for moderate calcification, they do good. And if you actually do rotational atherectomy and then put in a cutting balloon, you actually are doing a good, even a better job of making sure that the lesion will expand to the best, even inside a stent. And that's, finally, I think you're going to enjoy you must remember that the best non-compliant balloons are the ones which are truly non-compliant. And that's why I say these ultra-high pressure balloons are going to be useful, because when you take up a non-compliant balloon and you say you find nicely sized and you say, I've taken a 2.75 and I'm going to go up to 16, 18 atmospheres. But if you really put in an ultra-high pressure balloon at 2.75, it's actually a 2.75. Even at 18 atmospheres, at 26 atmospheres, it'll be a 2.79 or a 2.8. So you can do really high pressure dilatations. You can actually make sure that you've got the best expansion without even expanding on the non-compliancy of the balloon. I think that's going to be the biggest advantage. So you had a great result, and there's only these points I was saying that we must remember that you had ultrasound guidance, IVUS guidance result. If it wasn't IVUS guidance, what would anybody else do? They would do similar, but make sure that they had high pressure dilatations with probably an ultra high pressure balloon, which doesn't grow at all, and gone up to beyond 20 atmospheres all over the place. So what looked angiographically like 3 would have been 3 at 20, 22 atmospheres, what looked angiographically. And that's why if it's 2.5, it was great to do 3.5 in the beginning, because if your distal vessel is 2.5 and you dilated it with 2.5, your proximal has to be a 3.5.
Right.
Okay. So you so that's always the case. Never be satisfied with a 3 in a tapered vessel where distally you've done 2.5 and then proximally you end up with a 3. Cannot be it.
Thank you, sir.
Dr. Shahid, I've got a question here. If you had the option of using IVL, would you have used it in this case before doing the rota?
That's right. If I could cross it, then I would use IVL, because it's a 2.5 millimeter vessel and a 2.5 millimeter IVL is available. So I would have used a 2.5. The only problem is that when it comes proximally, that 2.5 wouldn't have done anything, because I would have needed a 3 millimeter IVL.
Yeah.
And it's an expensive device.
Yeah.
So that was fine in a 2.5. Now, had this vessel been, this lot of concentric had been in a 3.5 millimeter vessel, then it is definitely IVL. In a 2.5, rotablator is a very good option because it's a cheaper option. And if you've got the expertise, it'll actually crack enough calcification in a 2.5 millimeter vessel to get a good expansion. So for a 2.5 millimeter vessel, perhaps nothing apart from the fact that it's a balloon and makes it easy for you to do it if you're not good at rotational atherectomy, but actually it doesn't provide the advantage. It provides best advantages in the larger vessels where there's a lot of medial calcification and where rotablator is not going to touch that medial calcification.
Excellent, sir.
Thank you, sir.
Thank you.
We're happy to hear Nepalese fellows with us, also Malaysian fellow with us, sir. Sir, Dr. Arun Maski is here.
Right. Yes, of course.
Hi, hello.
Hello. Arun, how are you?
Yeah, fine, thank you. You have been an excellent teacher. After listening to your lecture, there is nothing much to ask to you. Just we are spellbound to see your lectures. Thank you, sir. So it was very excellent presentation. There's nothing much to ask. All questions are answered.
Thank you.
Thank you,
it's good to see you, Arun. It's good to see you.
Yeah, Dr. Mohsin, before finishing this, I want to ask Dr. Shahid a non-orthodox question that IBL lithotripsy balloon, whether we can use as an Oxford one, or how many times you can use that one.
So Saidur, what happens is that they've really been very bad at it. It's a self-destruct system. So firstly, of course, 80 pulses will finish it off. And in a diffuse disease, you end up using those 80 pulses. But the problem is that even if you use 40, after 6 hours, it self-destructs. So you can't even use it. So even if you re-sterilize it, it's not going to function. And the moment you attach it, it immediately shows non-functional. So
And that's a painful thing.
That's a painful thing. So you got to use it. So best is, of course, if you got a long lens, because then you can use the 80 segments, because otherwise for a short segment, you feel, my God, it's only got to use 20 pulses or 30 pulses and the lesion's open, and the rest you can't use any further.
Yeah, it's like
What's the price of IPL in India?
It's around, it's 2.5 lakhs Indian rupees.
Yeah. We are passing 2.5 hours time. Okay, Munwar sir, last comment from you. We are passing 2.5 hours, but everybody are enjoying your lecture.
Thank you very much, sir. Actually, we are amazed to listen Dr. Seth's lecture, and also very good to exemplary case presentation by two of our fellows. Done wonderful job. Actually, there's no comment at all.
Momenuzzaman,
I enjoyed thoroughly.
I have a comment. Momenuzzaman has been my first fellow, should we say, in the cath lab, and it's such great memories, because we traveled together to Sri Lanka. We had great fun time together, and then every time I would come to Bangladesh, he knows the intricacies of my life and intricacies of my habits. So every time when I visit Bangladesh, he knows exactly the things I like. And for years, he would, till I changed my habits.
Thoroughly follow you. Basically, I thoroughly follow you in toto.
He would give me a polo every time.
You are my mentor, definitely. And for you, I am here in this level. I salute always. Thank you, sir.
No, I mean, it's such a pleasure to see you all. But the trend was started by Momenuzzaman. That's how it all started. And after that, you know, it was, and so it's so good to see all of you. I mean, some of the work which each one of you is doing is just phenomenal. And so when Mohsin said that, you know, can you just even do this? I said, gosh, you don't even have to ask. It's indeed a pleasure for me to come and talk to you and just share, interact. It's always togetherness. That's what I feel. That's why I keep saying, I'm going to come there, not for anything else, apart from having a good joint dinner with you all together. Have a big dinner, have all my colleagues who, I can't call you fellows anymore. I can only call you colleagues. Have all my colleagues there who I've mentored, and just spend some time together.
Thank you, sir.
Thank you,
sir. Thank you, sir. Thank you, sir.
Okay.
Thank you, everybody. I thank everybody for the participants.
Hope to see sir after the flight is established and situation is improved.
Absolutely.
And we'll get you here, and we'll be there in Escorts also.
Thank you so much. Thank you all of you.
Thank you.
Be safe, be good, and I'm praying for you all, and that's always there.
I think we have really enjoyed the whole session, the conversation, the presentation, and everything. And the cordiality, the generosity that manifested by his words and the presentation and everything, this really very heartwarming and touching to us. And as I have already said, all of us who have not been directly mentored by you also feel take you as a teacher, as a guru, because our gurus have been trained by you. So they have imparted the wisdom they have learned from you. And so the next generation also getting that from us. And so as a whole, you have been a mentor to many of the interventional cardiologists of this country. And from IPDI, we're really lucky, and it's our privilege that you have agreed to give this lecture, this beautiful, elaborative, and very clear-cut message, what to do, when to do, how to do. And the perspective that we face in our labs, you have taken that into consideration and allowed that into your presentation. How should we take care of these particular situations? We are really grateful to you, and I hope in future also we'll be getting many more lectures from you, from this platform and many others.
Thank you, Abdul. Thank you very much. Thank you.
And to the panelists and the audience as a whole, the presenters, and the Beximco Pharma who have made this whole thing possible and about, we are really grateful to all of you. Mohsin, you can finish.
I also thank Boston Scientific Boston Scientific.
Boston Scientific, yeah.
And vaccines are always with us last 3 or 4 months. Thank you, Professor Dr. Syed, with us. We are so much grateful to you. We are ready to next month or next 2 months you come and again lecture.
Absolutely. Anytime, once a month, I think I should be with you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you. Bye. God bless.
Happy life and long live, sir. Thank you, sir.
Thank you. Thank you. Assalamu alaikum. Allah Hafiz. Take care.
Allah.
Thank you, sir. Assalamu alaikum.
Assalamu alaikum.
Good night, everybody.
Wa alaikum
Good
salam.
night.
Good night.